Migraine treatment is usually divided into three broad categories. One category are the non-pharmacologic therapies, the second are acute treatments, and the third are preventive treatments. So in terms of non-pharmacologic approaches to migraine, one very important thing is to help patients identify and avoid headache triggers, and triggers often include poor sleep, stressful life events, and an array of dietary factors including red wine, fermented cheeses, and so forth. So by having patients keep headache diaries, they can often identify factors which are avoidable, which will help them reduce their headache frequency. It's also useful in terms of non-pharmacologic treatment to advise patients to lead very stable lives, almost to do what your mother told you to do when you were a kid. You know, eat regular meals, go to bed at the same time every night, wake up in the morning at the same time. If maybe consider practicing some sort of stress management technique, yoga, meditation, mindfulness practice. All of those things are quite useful. Acute treatments are taken at the time of headache to relieve pain and restore function. And for migraine, the most commonly used acute treatments are nonsteroidal anti-inflammatory agents and triptans. So for mild headache, over-the-counter pain relievers like ibuprofen and naproxen, marketed as Motrin or Advil and Aleve, are helpful for some patients. Most patients who go to the doctor with headache need something stronger, and prescription nonsteroidals for mild migraine are usually the first line of therapy. The real mainstay of acute migraine therapy are the triptans, and there are 7 marketed triptans in the US. In choosing which triptan to give, it's important to think about whether the patient needs oral versus non-oral therapy. Many patients I see who failed the treatments they've received from their primary care doctors either have rapid onset of headache or very prominent nausea or vomiting, and in those circumstances, oral therapies may be ineffective. Part of the reason for that is that during migraine attacks, people develop gastric paresis, where they fail to absorb oral therapies. So there are triptans available as nasal sprays, as injectables, and there's a new product which is a transdermal patch that's applied to the skin, and all of those methods have the advantage of getting drug in when drug can't get in through the gut. The third category of migraine therapy are preventive medicines, and preventive medicines are taken on a daily basis whether or not headache is present, to reduce the probability of getting an attack or to reduce the number of headache days a person experiences. Preventive medicines are particularly useful in people with frequent migraine because there's some evidence that headache begets headache, and certainly overuse of the wrong acute treatments can make headache disorders worse. So if you can control headache frequency with preventive medicines, patients will often do better. Whereas virtually everyone needs the non-pharmacologic approaches and virtually everyone needs acute treatments, perhaps 30 to 40% of people with migraine need preventive treatments, and the people who need them are those who have frequent severe headache or a poor response to acute treatments. The FDA-approved preventive treatments for migraine fall into the family of beta blockers, particularly propranolol and timolol, anti-epilepsy drugs, particularly topiramate and divalproex sodium, and then for chronic migraine, also on botulinum toxin A. But by focusing on these 3 categories of treatment, it's often easy to reduce the impact of migraine attacks when they occur, and also to reduce the number of attacks people experience each month.